True. Yeah.
It's like contradiction in terms, I'm afraid.
Absolutely. Yeah.
Okay, we are live on Facebook, so I'm just going to say good afternoon, good morning, welcome. Okay, nobody's in on Facebook. We do have people in the room, so if you're in here with us on Click Meeting, good afternoon, good morning to you. Thank you very much for joining us. We have the Prof, the chair of our medical advisory board, James Neuberger. So thank you very much, on his own Wikipedia page, no less. So James, thank you very much for joining us. Welcome today. Nice to have you back again. I know you've been off jabbing people and helping out with the vaccination, so thank you very much for that. So welcome.
Chief. Yeah, Chief. Sorry, I'm just answering somebody. Yes, welcome everybody. I'm James and Robert. Yeah, so it's nice to see you back, James, and I hope you're very happy sticking your nose into people. I'm sure it gave you a feeling of being needed, wanted, loved, and all those kind of things.
No, I wanted to use blunt needles, but they wouldn't have it.
What was quite interesting was you saying that when you had vaccines left, how hard everybody worked to get them used up, and you were reaching out to police and ambulance and staff and family, and I thought that was fantastic. So great stuff. It's nice to hear these things. Anyway, everybody, so we're in. Have we got anybody in on Facebook just yet, Robert? Well, it's working, isn't it?
Yeah, we've got 5 people watching, so it's
right.
It's
okay, right. We've made a start. Okay, so have we got questions for the good professor?
We do indeed.
Because I've got a belter for him coming down the line, which is coming from some of the people I've been speaking to over the last month. Can I do mine first? Actually, can I do mine first? I don't think you're going to give me an answer, James, but I want you to think about it because I'm going to hit all our medical trustees with this one. That many, many, many hundreds of thousands of people with PBC have bowel issues, and most of us get told it's IBS, and it's all very, you've got the serious, not the serious, severe IBS. And many, many, many of us feel that there's just probably a wee bit more to it than meets the eye. So maybe, I know I'm not asking you a direct question as much, but I think maybe, so the business of the fatigue, well, I'm tired as well, that's been all resolved. The brain fog, nobody really listens to that, that's kind of been resolved, we know that's there. So I wonder maybe for the future we might do a bit of bowel tunneling, if you like. And I think it's too, seriously now, I think it's too large an issue for it to be put down to IBS. I don't know how we resolve, well, I think it might be worth a wee questionnaire and find out what's happening to people. You must hear it in the clinic, James.
Yeah, I mean, I think a number of thoughts come into my mind. Firstly, PBC, is associated with other diseases, as you'll know. For example, one of them is celiac disease, where about 4% of people with PBC have celiac disease. This can be readily tested for with a blood test, and if that's abnormal, there's a certain antibody against the transglutaminase, and then you need to do a small bowel biopsy, which is done through the endoscope, and that will confirm if you do have celiac disease. I think there are other people, this is irrespective of PBC, who have an intolerance to gluten. They find that gluten gives them a bit of bloating and diarrhea. They don't have celiac disease, but they may choose to avoid gluten. So that's a separate syndrome. Another condition that's, I think, more associated with PBC is ulcerative inflammatory colitis. And some series have suggested there's an increased association, not all. And that may be another feature that gives, just as thyroid disease or dry eyes and dry mouth. I think there's another aspect you have to look at, and that is there will be some people who go to their GP with irritable bowel or abdominal pain and discomfort, bowel disorders. They have a battery of tests, including liver tests. They're found to have a raised alk phos, and so they're picked up as having PBC, although that may be coincidental. I can see potential mechanisms by which, for example, the abnormal bile that is secreted by the liver into the bowel could perhaps cause bloating or other symptoms. But the simplest, and it's not that simple, is to do a questionnaire of people with PBC. There are two problems with that. The first is that it's likely that more people with bowel problems will respond than people without bowel problems if they've got PBC. And secondly is, what do you compare it to? When we do drug trials, for most trials, there is a placebo group. So people get essentially a sugar pill. And I've sat on data monitoring committees where we look at the side effects that patients report. And it is remarkable how many people get or report side effects from a placebo. So maybe 1 in 8, 1 in 9 people will report quite significant diarrhea that they attribute to the placebo. They're not making it up, it's a real symptom.
No, I understand, yeah.
So you'd need to say, well, if you look at bowel problems in people with PBC, to see if it's increased, who do you compare it to? You can look at aged matched women, for example, and see how many of them get bowel problems. But how do you get the so-called normal person? You could take somebody with a different medical problem, but there again, that may give you misleading. So it's quite a difficult question to answer, but an initial finger in the wind, if you like, would be to use the app, to use the feedback we get from our members to say, do you have bowel problems? What sort of problems are you getting? And then we can see the extent of bowel problems in people with PBC. That will give us an inkling, as I say, people who are not members, people who have no bowel symptoms are less likely to respond than those who do. That's human nature. But it'll give an idea. So we can say that this is an issue for people with PBC. What we can't necessarily say is this increased in PBC? Is this related to the PBC? Is it related to the treatment? We know Questran, for example, can cause bloating and upset. So it's worth looking at. But the first step is to get some data from people about the nature, the severity of their symptoms, maybe some of their medication, and that will give you an idea of the extent of the problem. So it's a long-winded answer, but
no. As you were talking, I'm scanning through kind of all the extremities, the severity of what I've heard from people. And normally, by the time they speak to me, it's I was out walking the dog and I needed to find a bush, or I had an accident. People are telling me about quite severe stuff, and what you're saying is absolutely correct. And I see the dilemma. So I think I will go away and have a think about it, and then I think we'll maybe talk some more. But I think I would like to put my hand on my heart and say to our members, our service users, that yes, we are taking it absolutely seriously, and we will try and find out a bit more, and which we will do. Is that reasonable to say that?
Yeah, and these questionnaires are really important. Robert's running one about itching.
Yeah.
And if there's anybody listening who hasn't completed that questionnaire, please do so, because the more information we get, the more powerful is our strength to go to pharma and say, look, this is still a problem. But unless people report their problems, we can't do so much.
100%. Absolutely. That's fantastic. Thank you, James. That's giving me quite a lot to think about, which is good. Robert. £10. £20, did you say?
Yeah, that's what happens when you have dogs and you think, yeah, I'll just keep it nice and quiet, and then there we go.
That
So
dog's lying here beside me, very quiet.
James, thank you very much for the primer. So I'm just going to talk about the app if I can before I come into questions. So first off, already, and we've only been live a couple of months, if that, but we have already over 190 responses to the itch survey, which is fantastic. But please, please, please keep them coming in, especially if you've answered previous surveys, because what we can do is cross-reference percentages in terms of, so we haven't asked this survey, for example, if your clinician has asked you about your symptom burden, but we have asked that in previous surveys, so we can cross-reference those answers. So please, please, please get involved in all the surveys if you can, because the more numbers we have, the louder your voice is, and the more chance we have of actually making a difference in your care pathway.
And can I add on to that, Robert, that if you don't itch, do what I do, say that you don't itch, and if you do itch and your itch is treated, tell us that too. We want to know everything, okay? Yeah. The more we know, as Robert and James says, the more we know, the more we can help. And we can,
Yeah, perfect. Okay, that's helpful. Right. First question. So I've got a couple of concerns about this. So I'm going to ask you about best practice once we've got the answer. But the initial question is, somebody who was diagnosed in 2013, have now in 2019 diagnosed with hepatic encephalopathy. They've had an endoscopy for varices, but they've not had the results yet, so I'm hoping there weren't any. But the first question is, are there any medications you would recommend for HE other than just the lactulose?
Yes, is the answer. Just for those who aren't familiar, hepatic encephalopathy, or HE, is a particular complication of anybody with advanced liver disease. And it's manifest by, it can be very severe, presenting such in coma or confusion. It can be much milder, making people a little bit muddled, a little bit slower. Some people have difficulty in doing fine movements, so their writing changes. They have problems doing zips or fastening buttons, doing their shoelaces, sewing, that sort of fine movement of the hands. It may also be associated with night-day sleep reversal. So you become, if you like, a teenager again, where you sleep during the day and wake during the night. So it's a spectrum of disorders from the very mild and indeed subclinical encephalopathy to coma. What causes it? Well, normally when you digest food and the actions of bacteria in the bowel cause a lot of chemicals to be released in the bowel. They get transmitted to the liver through the portal vein, where they get removed from the blood and detoxified and excreted. In some situations where you have a shunt, so the blood bypasses the liver, and this will occur in cirrhosis, this will occur after a TIPS, then the blood goes straight from the bowel into the systemic circulation, where it goes to the brain, and chemicals in the blood, which would normally have been removed by the liver, interfere with the functioning of the brain. The diagnosis is made predominantly by doing an EEG, an electroencephalogram, which is the brain equivalent of an ECG, or EKG as the Americans have it. And that will show characteristic patterns. So it can be mild, it can be severe, and it can occur, I say, after a shunt, or even with people with quite mild or not very advanced liver disease. The old treatment used to be with lactulose, because And that acts by giving you diarrhea, and you want to have 2 soft motions a day, and you adjust the dose of lactulose. And it acts partly by getting rid of some of the bacteria in the bowel, and also by altering the balance of bacteria. So there are fewer bacteria that produce the chemicals that cause confusion. And it's not widely appreciated for obvious reasons that most of what you excrete when you have your bowels open are actually bacteria rather than foodstuffs. That's by the side. Now, there's been a new treatment that's people are using I don't think it's available in all countries. We used to use an antibiotic called neomycin, which is not absorbed. It was given to treat severe infections, but had to be given intravenously. If you give it orally, it's not well absorbed, and that can and was used. But one of the problems is it was associated with deafness. So if you have teenage children, taking neomycin might be a solution for sanity, but that's a separate argument. The other treatment that has come in recently is a drug called rifaximin, which is another antibiotic which is used after some forms of infectious diarrhea. But rifaximin is an antibiotic. People give it twice daily usually for people, and the combination of lactulose with a dose adjusted to have 2 soft bowel actions a day plus rifaximin is usually a very good treatment for encephalopathy. In some people it's inadequate, and then liver transplantation is probably the best option. But whether you need lactulose or senna or other laxatives, I think, is uncertain. Traditionally, certainly, we use lactulose, and then rifaximin is the other treatment for encephalopathy. One further point about encephalopathy, just to mention, is if you have encephalopathy, you really should probably not be driving. And we had an article in the Bare Facts last year, I think it was, where we worked very closely with the DVLA. And I have to say I was impressed and rather surprised by the sensitivity in which they respond. They have a duty, obviously, to protect not only the motorist, who should have the right to drive, but also to protect the public, who have a right not to be run into by confused drivers. But if you have encephalopathy, you really should not drive. You should inform the DVLA, and they will take medical guidance as to whether it's safe and legal for you to drive. But if you've been given a diagnosis of encephalopathy and you drive, you're in breach of the law. And if you injure somebody as a consequence, you're in serious breach. So just be cautious.
Legal.
But I think that's probably as much as I want to say about it. So the short answer to the question is lactulose or laxatives and rifaximin are the cornerstone of treatment. There used to be a vogue for giving a low-protein diet. A, that wasn't very effective, and B, it resulted in malnutrition, muscle weakness, and deterioration in the quality of life. So we say have a good, sensible, balanced diet. Don't reduce protein. Finally, if somebody develops acute encephalopathy, they go off quickly. One always needs to look for a cause. And the common causes are anything that puts a stress on the liver. So a gastrointestinal bleed, a episode of infection can do that, or the inappropriate use of some drugs, such as sedative drugs, opiates, and so on. So if somebody develops encephalopathy, you should always ask yourself why, as well as how do we offer treatment and what advice do we give to the patient. and their family if appropriate.
Perfect. Thank you, James. So question with regard to that. Do you remember which company or companies make the rifaximin?
No. I mean, I can look it up, but I don't know offhand.
Right,
we
okay.
tend to prescribe generically, and the manufacturers, I'll just see if I can pull it up.
The reason I'm asking is we were asked to look at a patient information leaflet for another compound that was relatively recent for HE, but I can't remember the name of it. That's all. And I think the fact that you're calling it rifaximin, which is a generic name, could be what's throwing me. But that's okay. And yeah, so you kind of pointed to one of my concerns is the fact that, you know, we have somebody who it would appear is last in the hospital at 2019, diagnosed with HE and not really knowing where they are with their varices. So again, do we have any advice in terms of what they could or should be doing in terms of contacting their doctor, asking any questions, any follow-up appointments?
Right. I mean, one of the trade names for rifaximin is Xifixanta, which is not one I've known of. And another one is Targaxan.
Yeah.
Does that ring any bells?
It does. Targaxan. Yeah. Okay, that's fine.
Yeah. Okay.
Thank you.
Sorry, with varices, I mean, that's a separate issue. You can have encephalopathy without varices. You can have varices without encephalopathy. So, for example, if you have a shunt in place, whether it's one made by the radiologist to save your life or it's a natural shunt, you may not have varices, but you have encephalopathy. In acute liver failure, you have encephalopathy without varices. So you may have varices, and certainly if you have advanced liver disease, whether it's PBC or any other advanced liver disease, you may get encephalopathy, you may get varices, and the only reliable way to detect those is to do an endoscopy. You can get some guidance as to whether there's likely to be varices by looking either at the FibroScan report, the ELF, spleen and platelets and other blood tests. But endoscopy is the way, and the rules for varices is quite clear. If you have cirrhosis, then you should have an endoscopy to look for varices. If there are no varices, then no treatment's required, and you should be rescoped in 3 years to see if they've developed in that interval. If they're significant varices or they show certain features which are associated with bleeding, you should go on one of the treatments to reduce the risk of bleeding, whether it's medication such as carvedilol or whether you have banding or both. If you have very early varices, then you repeat annually. So the only way to know if you have cirrhosis, you should have an endoscopy to look for varices, and the follow-up afterwards will depend on whether you have varices, and if so, how bad are they. But whether you've got encephalopathy or not shouldn't affect whether you have an endoscopy.
Okay, perfect. Thank you very much. That's helpful. Chief, any thoughts on that?
No, I think that's been covered quite well.
Okay, perfect.
Actually, I would just say, don't be afraid to email your consultant or phone or leave a message. Don't be afraid to do that. If you're a bit worried, concerned, please contact the hospital. They wouldn't want you sitting, worrying, or at risk in any way. So please do.
That's a fair point. Thanks, Chief. Okay, thank you. Okay, moving on to another question now. So this is to do with COVID vaccination. So there was a lady who went for her second vaccination at the weekend. She was asked at the time if she was having any blood tests in the near future. Now, she didn't follow up at the time, but she is concerned now. She's due to have a blood test for her thyroid. Should she delay that blood test? And is there something that happens with the COVID vaccination that would alter your blood test results?
That's a belter of a question. I like that. We need more of those.
I'm not entirely sure what's behind that question, to be honest.
Yeah.
When I was doing the vaccination clinics, it wasn't one we were asked to ask, and my wife they have enough staff, so I've been released, but my wife is still doing it. I don't think she's asking those questions. I believe that occasionally you can get minor disturbances of the liver tests, but my feeling is I don't know why that question's being asked, and I would go ahead and have your blood test as arranged.
Yeah.
Okay.
Yeah.
Perfect. That's helpful. Thank you. Chief, any thoughts on that?
No, I think it's a great question. I'm glad it was brought to the table. But I think sometimes people, it's like hairdressers, they kind of make conversation, don't they? It could well just, they were making conversation. But no, I have never heard anything either that would explain that. But great question. But it's good to bring these things out in the open and ask.
You're absolutely right, because some of these questions that produce, I'm not going to say a non-answer, but an answer that rules out concern is actually really important, because I'm sure something that goes through.
And we all sit and worry, and people, that live with PBC, we probably look well and we go about our business. We still worry about things.
Absolutely. So good job, well done, fantastic. Right, James. Next one now. So we have a promotion. We have a follow-up, because we're talking about the chief having irritable syndrome. Oh no, sorry, irritable. No, right, okay.
Very funny.
So the question is, somebody has had IBS for a number of years before finding out about their PBC, but since their diagnosis, I presume, of their PBC, their bowel movement has gone from permanent diarrhea to extreme constipation. Could this be down to the PBC?
I would be very reluctant to put down a change in bowel habit to that. It may be related to the medication, whether PBC related or not. That's always something to consider. But any change in bowel habit should always incur the question, why? What is the cause? And there are many causes. And if it's recent and progressive, then that's a very different situation from if it's long-standing and stable. But if in doubt, if there has been a change in bowel habit, mention it to your doctors and take it from there. It's probably nothing serious, but don't put everything down to the PBC.
Yeah.
So, okay, perfect. That's helpful. Chief?
No, that is really, really important, that any change of any kind, you report it, and it possibly nothing, doesn't matter, but it gives you peace of mind as well. But you do report changes.
Yeah. Okay, thank you. Right, we've got another cracking question. So I hope everyone who's watching has their pen and paper at the ready. So this is a peach of a question. So looking forward to the answer to this, James. Somebody's written in that they have their annual review next Monday in the form of a telephone call for the second year running. So they are currently putting a list of questions together, but they wondered if there's anything that you would recommend that they should ensure that they ask.
I think the thing, what I would want to know the medication, why are you on the current medication, and particularly with ERSO, to be sure this is the right dose. I would want to know what the latest blood tests show, and in particular the alkaline phosphatase, because am I on enough ERSO? Am I an ERSO responder? If so, good. If not, what about second-line therapies? Another thing I'd want to know is, has my thyroid function been tested in the last couple of years? Because I think it should be. Another question is, do I have evidence of significant fibrosis in the liver? In which case, do I need ultrasound? Do I need endoscopy? Those are the sorts of questions. I would hope they would be unnecessary, but the doc normally asks, what medicines are you taking? What are your symptoms? And then they would review the need for endoscopies, for various ultrasounds, fibroscans, additional blood tests, etc. You may or may not want to know whether your liver's progressing. I don't think that's a very helpful question, because doctors don't really know the answer. They know if you're a nurse responder, you know your prognosis is very good. If your response is not so good, your prognosis may not be so good, but it again depends on age and many other factors. One question I'd want to know is, how much alcohol can I safely drink and stay sober? And of course, the safest answer is none at all, and that applies whether or not you've got liver disease. But I think the clear thing is, am I on the right medicines at the right dose? Are there ones I don't need? What's my alkaline phosphatase, my other blood tests? And have you checked my thyroid? And do I have fibrosis or advanced fibrosis? And do I need further investigations for the varices?
I'm going to add to that.
Yeah, I'm sure there are others, but yeah.
When you tell your doctor, your specialist, what medication you're currently on, don't be saying, "Oh, is that wee green one?" Do you know what I mean, with a little V on it? Have a list of the medication and the amount that you're taking. That's it. So just write it down. I take 10 milligrams of this and 4 milligrams of that, and how many times a day. Have it written in front of you so as it's there. And the second thing I would say to you, if there are any changes since your last chat with your physician, any changes in your medication, but any changes in you and your symptoms or anything about you don't understand or feel is significant, just mention it. Gotcha. You're not top of the class yet, Prof.
Perfect. Okay, thank you. So actually, so the medication thing again, and this has come up, is really important. I know that George has spoken to as part of the patient clinician partnership and that kind of thing. So let me reverse the question. So James, what additional information should the patient bring to the appointment that's going to be helpful for you to do your best job?
I'd want them to know, as I say, to know what medications are on. I did a clinic Tuesday, and I had about 3 or 4 patients who did not know their medication, could not find their list. And it's very frustrating because you need to interpret the blood results. You need to interpret the symptoms in terms of their medication, and to know the dose, as you said, the medication and the dose and frequency is really helpful. So I want to know existing symptoms, how they are, new symptoms, how they are. It's always more difficult if we share care, and we do for a lot of our patients in Birmingham, because we rely on information from the referring hospital. When were you seen? When did you have blood tests? So that information, but mainly what medicines are you on, and how are you? What are your symptoms? Have they changed? I'm also quite interested in the weight. Has that gone up or down? Again, not necessarily good or bad if the weight goes up or down. Particularly with COVID, a lot of people's weight has gone up as they've been isolating. And increased weight can also be fluid, for example. I'm also surprised how many people with high blood pressure, have got blood pressure machines at home but don't use them. So again, when we're doing a telephone consultation, if they can say, yes, I checked my blood pressure twice over the last week and it was whatever, that's really helpful. But the number of people who say, have you checked your blood pressure? No. Do you have a blood pressure machine? Yes. You say, well, could you check it and write down the results and we'll discuss it then. So those are the main thing, I think. But having the medication and note of any symptoms, and also I want to hear of concerns. It's a waste of everybody's time to have a consultation if the patient doesn't raise their relevant concerns. Obviously, if it's to do with the slugs eating the petunias, that's not relevant. But other concerns is really important to have those clear. And as we said before, have somebody write down the questions, and if you want, have somebody with you to listen to the answers.
Yeah.
Yeah.
Perfect. Thank you so much.
I think maybe we could put him back to the top of the class then, Robert, just for today. I think it's well done. You're back where you should be, James.
Okay, perfect. Thank you. Got a great question in the room now. So I'm going to ask you, James, what is the difference between a nodule and a polyp found on an endoscopy? Could a polyp found by one endoscopist be considered to be a nodule by another?
The answer is yes. A nodule tends to be a little, to my mind at least, and I'm not sure if this is the formal distinction, a nodule tends to be a little bump on the wall of the stomach or duodenum, whereas the polyp is a slightly elongated one that sticks out a little bit, like a polyp that you see like the arm of an octopus or whatever. The distinction is quite important, because if you want to remove the polyp, so a polyp to my mind has a neck, and so if you want to remove the polyp, you can do that by putting a snare around the neck and frying it basically. Whereas a nodule, that's harder. To remove nodules, what you can do endoscopically is to put an injection of fluid underneath the nodule, raise it up, and then snare it. So a polyp is a slightly different. I think of a polyp having a neck, where the nodule is just arising out of the lining of the stomach or bowel or whatever. Okay.
Perfect. That's helpful. Thank you. Chief, I'm going to come to you now, because we had a conversation through the week. Now, somebody, did they mention, was it a rough liver or a...
Yeah, a coarse liver.
Coarse liver. Well done. Thank you.
Yeah.
So, and again, the question was, what does that mean, and does it have any implications? And we weren't entirely clear. And James, you might not be entirely clear either, but I thought we'd just ask the question as we were here.
Yeah, no, it's a very good question. And very often when radiographers or radiologists are doing liver ultrasounds, they will describe the appearance of the liver as coarse, which is really a reflection of the way the echoes come back to the monitor. Does it relate to the degree of fibrosis or cirrhosis? Not really. If you want to diagnose cirrhosis, then ultrasound is a very poor, unreliable way. It's just a description of how the ultrasound looks, and it doesn't correlate very well with the degree of inflammation or the degree of fibrosis or scarring of the liver. And it means it's not normal, but it doesn't tell you much more than that. But then if you know you've got PBC, you know your liver's not going to be normal anyway.
Okay, perfect. Thank you.
Yeah, that's helpful to know, actually.
Okay, Chief, any thoughts?
No, that was just nice to get that answer, because I've never heard of it before, I must admit.
Good. Okay, thank you.
I mean, I have to say that we don't like coarseness in Birmingham. We go for refined, as you might appreciate. So,
a classy establishment, is it?
Absolutely.
Okay. So this is the unofficial plug section. So I'm going to talk about next week, because it's International NASH Day on the Thursday, the 10th of June. So we have a particular event which will involve Dr. George Mells, amongst others, talking about fatty liver disease and NASH, and that combined with PBC. So that's important.
Can you say what NASH is, please, Robert?
Sorry?
You explain what NASH is.
So NASH stands for non-alcoholic steatohepatitis.
Fatty liver.
So it's when the fatty liver then progresses on to particular damage within the liver itself. So you would maybe start with fatty liver and then you'd maybe progress to NASH, although not everyone does. But if you want to hear a far more scientific and far more detailed definition of that, then that's next week. So, but I'm aware that we've got people in Australia at the moment. We've got people in the US who are watching us. So again, if you're new to this, if you've never seen us before, it's not normally like this. Usually it's better. But we're delighted to have you here with us today. And please do like the foundation on Facebook. Please do follow us on Facebook to make sure you get the notifications so you know that when we're live, you can join us and register with us via our website. But just to make use of the services that we have and the information and support that we can provide. So I just wanted to share that before we came to James with our next question. So James, we have somebody who has extremely stiff, painful hands and feet, but also hips, sweats on occasion, fatigue and brain fog. Now, this is an interesting concept that comes up periodically, and the question is this a PBC flare-up? Or is it more likely to be another condition? And so we'll talk about PBC flare-up first, and then we'll move on.
I've never ever heard any that ever been said, a PBC flare-up.
So I've heard
I'm not sure it's accurate either. I'm not sure it's accurate.
I'm not sure. PBC, unlike PSC, primary sclerosing cholangitis, is a very slowly progressive disease that doesn't fluctuate greatly in severity. Mm-hmm. Whether a flare-up, which you might get with arthritis, with autoimmune hepatitis, with sclerosing cholangitis, doesn't seem to occur in PBC. You may get deterioration in PBC as a result of, say, a bleed, a serious infection, for example, or inappropriate use of certain medications, but that's not usually called a flare-up. Maybe that if you have this sort of autoimmune end of the spectrum of PBC, you may get some flare-ups, but it's not really a concept that is common in PBC, and with the exception of the possible autoimmune end of the spectrum, it's not a term I would use. People with PBC can and do get joint problems. Sometimes they have associated rheumatoid arthritis. Other times they have inflammatory arthritis. And several years ago, this is less talked about now, people used to get small joint disease, which is thought to be due to enhanced immune activity with little molecules called immune complexes in the blood, which cause inflammation of the small joints. So if a patient gets severe, significant arthritis, I think you need to have further investigations, probably by and referral to a rheumatologist, because rheumatoid arthritis is a nasty progressive disease. And the old amongst us, and I'm not going to mention Collette's name, will remember seeing the old people with really quite very significant deformities of their arms, their hands, and other joints. Now, with modern medication, we rarely see that. and the so-called DMRDs, disease-modifying drugs. The course of rheumatoid arthritis has changed dramatically and for the better. And these old-fashioned rheumatoid joints are very much, thank goodness, a thing of the past because we're getting better at treatment. So if somebody has severe arthritis, then they need an expert opinion. If it's osteoarthritis, well, that's just tough. That's the price you pay for getting older. If it's inflammatory arthritis, which may be rheumatoid, may be one of several other arthritis causes, does need proper evaluation and proper treatment, not only for pain relief, but also to prevent the deformities in later years, which can be really quite significant.
Perfect, thank you.
I think I would say to that, calling that a flare-up, I just feel it's a bit of a negative connotation, because living with PBC, your symptoms can last for hours, days, weeks, maybe even months, and it doesn't indicate how severe your disease is. And you could have very, very mild PBC and have a spell of, pretty awful fatigue, itching, etc. But to be symptom-free is quite unusual, but it tends to be just, they come and go and they come and go. I've never, ever heard it called a flare-up, but I would certainly endorse what James is saying, and get to see a rheumatologist and just get to the bottom of this pain that you're suffering.
Yeah, okay, thank you. And I was actually going to follow up and ask about this, this separation between blood tests, between any liver damage and symptoms, and the fact that they don't always correlate, or in fact they often don't correlate. You've covered that fantastically, so thank you. That's really helpful. So perfect, thank you both. Okay, so we've got somebody who, again, is a follow-up from the earlier conversation. So they've got a telephone appointment coming up, had pains in their liver area for a while, haven't had a scan, been in and out of hospital. They feel they need a scan. What can they do? What should they say? Who should they ask in terms of finding out what's going on with the liver pain, please?
Liver pain is one of these really difficult issues. A lot of people with PBC complain of pain around the liver, and what that is due to, we just don't really know. The liver itself does not have pain fibers. The pain fibers are in the capsule, the outside, and anybody who's cooked liver will know about the capsule. And the humans have their own, and it's swelling of the capsule, tension in the capsule that causes pain. So if you have hepatitis, when your liver swells quite quickly, in some acute hepatitis, it may be painful. Other structures around the liver that can cause pain include the gallbladder and gallstones, and people with PBC do have an increased risk of gallstones, although the great majority of gallstones are asymptomatic, and unless you're private, then there's no reason to take them out. Pain in the side may come from the liver. As I say, it may come from other areas. It may be from the bowel, from the pancreas, from the back, the spine, the nerves, the muscles. So I find it on a telephone consultation very difficult to identify the cause of the pain. The main reason for doing an ultrasound in this situation, if you think the pain sounds like gallstones or various types of gallstones, that may be helpful. But as much as anything, it's done to reassure the patient and, of course, the doctor that there is nothing severe going on. Obviously, most people have an unspoken fear when they get pain it's due to cancer, and it's rare that cancer in the liver causes pain. One of the problems, indeed, is that it doesn't. So if you do, say, have a secondary in the liver from bowel or whatever, you don't know because it's asymptomatic. And so pain is rarely a feature of liver cancer. although that's what people worry about most. So I do ultrasound scans, as I say, more to reassure the patient there's nothing untoward, make sure there's no gallstones, there's nothing else in the liver. But it's unsatisfactory without examining the patient. And it can be very difficult to identify the cause of the pain. We've seen and continue to see people who have indigestion that becomes so severe, they're diagnosed as having possible heart attacks. So pain is very non-specific. And with telephone conversations, I say, it is very difficult to determine what the cause of the pain is, because you can't examine the person, see if it's likely to be from the muscles, from the spine, from the ribs, from the liver, from the bowel, from the pancreas, from the kidneys. And a history is helpful, but it's not reliable enough.
So this person should ask the specialist for an ultrasound?
Well, they should ask them whether an ultrasound would help. And depending on the nature of the pain, the length of the pain, associated symptoms, it may be they should go to their GP or to the hospital doctor and be examined. It may be an ultrasound would help. But it doesn't do any harm to say, why would an ultrasound help? And if not, why not?
Yes, absolutely. Yeah.
The only risk of an ultrasound really is if you fall off the table while you're being examined. It's a very safe procedure, but it is a limited resource like everything else in the NHS. And so there may be a little bit of reluctance to do it if there's really no indication. But if it's a worry, then raise it. And if you think an ultrasound should be given, ordered, requested, then just ask and say, why not?
Yeah. Allowed.
Well, you're encouraged to ask. And as I said before, just remember who pays the doctors, the nurses, the radiographer's salary. It comes from the public purse.
Yeah. Good. Another tenner, Robert.
What's that?
Sorry,
he silenced his mic again.
So I hadn't seen it because I was reading the Facebook page and I wasn't on the Click Meeting page, so it's entirely my fault. So apologies, everyone. So, and that was me saying that actually, I'm aware of time, so we need to move on, other than having to repeat myself. So apologies. So on the subject of pain, we've got somebody with a swollen abdomen, constant lower back pain. So they're concerned, is it a spleen thing? Do we know what could be going on? Could it be PBC? What would they be doing next?
Don't put it down to your PBC. That's your first thing. If it's lower pain, there are many causes. If there's distension and bloating, it could be fluid. And that's often a difficult one. People find it very difficult to distinguish between bloating from fluid, bloating from gas. The two can go together, of course. Examination often makes it easy, but ultrasound is definitive. But there are many causes of abdominal pain. It could be ovarian problems, it could be pelvic problems, colon problems, spinal cord, vertebral columns, pelvis, and it's so dependent on associated symptoms, severity. But don't put it down to your PBC. Go to your GP and be examined, get a history, and take it from there. But don't just lay it down to the PBC, and particularly if it's causing symptoms. I mean, we talked earlier on irritable bowel syndrome. It's people so often underestimate the impact of IBS. And when you have to plan your shopping by knowing where the nearest loos are, which is the McDonald's that's got the clean loos, and so on, it does unfortunately attract a certain degree of mirth, but it's absolute misery for the person and their families with it. And living with diarrhea, particularly like with IBS or inflammatory bowel disease as well, when it comes on suddenly and profusely. And it is so demoralizing when you have accidents. So don't underestimate the severity of the symptoms, even if it's not reflected by the severity of the cause.
Yeah.
Okay, perfect. Thank you. We've got somebody here whose bilirubin has gone from 64 to 88 in the last 2 months. Sodium levels are low. So the question is, can I take salt tablets? Would we have any other information about that we could share?
If the bilirubin has gone up and it's checked, then I would want to know why. And there are many causes of that, but obviously it could be disease progression, but there are many other causes. A low sodium, again, has several causes. In fact, the most common cause of a low sodium in this country is actually not salt depletion, but water overload. So if you like, you've got the right amount of salt, but you put too much water, or the body doesn't get rid of the water, so the salt gets diluted. And the treatment of that is actually water restriction or diuretics. So again, a low sodium, it depends how low, it can be caused by diuretics themselves. It can be a sign of liver disease in itself. So like with a high bilirubin or the rising bilirubin, the question is why? It may be something serious, it's probably not, but you need to know what the cause is. But again, with all blood tests, if they show a sudden and unexpected change, always check first, because you do get the occasional rogue result. And a rising bilirubin has many causes, but if it's a spurious result, then you don't have to worry. But don't ignore it, repeat it, and think what has caused it.
Okay, that's helpful. Okay, thank you. Last question for today then, and I'll come to you first, James, because I know the Chief's going to have something to say about it after you. So we've got somebody who's saying on Facebook that neither my doctor or my employer has ever heard of PBC. So it's not a question per se, they're just sharing that information. But so I'm going to come to you, James, with regard to the doctor, and then we'll probably come to the Chief with regard to everything else around that. But what can a patient do in terms of sharing information with their doctor?
I think you mean with their employer. I think there are two things. One approach is for the employer to write to the doctor asking for a medical report and specific questions. The doctor can respond only if there's written authorization from the patient to do so. Most of the big employers have HR departments, and most HR departments look after the interests of the company, not the personnel. And one just has to accept that as a fact of life. So they should know, the big companies have pro formas that they want to ask. There's usually a box on that form. So the employee is asked to sign their consent, and there's usually a box saying whether you wish to see the report before it's sent. I advise everybody to tick that box so they see that report before it's sent. An alternative approach, and I do this for people who work for smaller organizations, is I will write a letter to the patient, send it to the patient. Dear Mrs. Smith, you're under the care of the liver unit in Birmingham, you're diagnosed with primary biliary cholangitis, this is blah, 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 blah. These are the implications, and I give it to the patient. And then what the patient does with it, the patient will see what I've written about them, which is important to see if it's correct. And B, what they do with it, if they want to show it to their employer or the milkman or whoever, then that's their business. Mm-hmm. So I think they're the two approaches. If the company has if the donor wants to know about it, the employer, just refer them to the PBC website, where they can get a lot of information. If they want to know about what it means for the individual, then, as I say, either a formal request for further information signed, authorized by the patient, or a letter from the consultant to the patient that they can pass on to whoever they wish. But I think those are the two approaches. But doctors are not, except in very defined conditions, are not allowed and would be struck off if they give information to a third party without consent.
Absolutely. And I'm quite forgiving of doctors who don't know about PBC. What I'm not forgiving of is the fact that they sit there a week later and say they don't know about PBC, because the information is there for them to access. And your employer is the same. I wouldn't be writing to my doctor, giving them permission to write to my employer about, I wouldn't ask for a report, but that's just me. And I have had a letter from my hospital before, say for insurance purposes, that was okay to travel. But I like the idea of explaining to your employer about PBC. It's fine, they haven't heard of it. Take our leaflets along, and as James says, access the website. And also to remember that symptoms with PBC, which might interfere with your working day, some days and not all days, or you might be having a particularly tired time, but you're not going to be tired all the time. But it's up to the employers to make sure that you're safe and that they have tried to accommodate your condition, because there are laws about these things, and so they have to accommodate you, and that should be a discussion with you, what you think might help and can they accommodate you. And the last thing they want to do is put you at risk, because putting you at risk puts the company at risk, and as James says, so they're acting on the company's best behalf. So there are various ways of doing it, but I'm quite forgiving of people that don't know about it, because when I was diagnosed, I didn't know either. So I'm okay about that.
And remember two things: that when people hear you have liver disease, they will assume automatically it's due to alcohol. And if you deny it, they say, well, of course, that's what alcoholics do. You just have to live with that, I'm afraid. Yeah. And the other thing is, people with PBC, even quite advanced or very symptomatic PBC, often look very well. And a bit of jaundice looks as though you'd be one of those few who've been able to escape the UK and get some sun. And to emphasize that how you feel and how you look don't correlate.
Yeah,
that's right. But also, you don't have to say you have liver disease. You can say I've got PBC. It's an autoimmune condition, and there's no cure for it, and it's a slowly progressive condition. You absolutely don't have to talk about livers and cirrhosis and this and that anymore. You know, this is about you, your life, your privacy. So you've given them enough information. Direct them to the website, and that should be suffice.
Sure.
Yeah. Indeed. And we've got somebody here in the Click meeting room saying that they sent their GP the actual foundation website link. And
well
again,
done,
we have a thing there where it's a thread specifically for healthcare practitioners. Yeah. So it's got lots of Latin, lots of Greek, but also lots of information to help them in their care of these patients.
Absolutely, yeah.
Okay, thank you both very much. I will now hand over to you, Chief, to close up.
Okay, thank you both very much. Just briefly say, most of you will have received my email now. I'd say I announced the news that Robert has been headhunted and will be leaving the foundation in just less than 3 months' time. I'm happy for Robert, sad for us, but we want to see him succeed in his next job. And we've had lots of kind messages in, but Robert, you know, everybody will miss you, but you're still here for a wee while yet. And they're talking about your 50th birthday party as well. So there you go. So, but don't worry, people. We will keep the services going. Everything will be fine. Robert's been with us 18 fine years. We've been here 25, and we will keep going. So, gentlemen, thank you both. James, I think you're back at the top of the class, which is nice. And Robert, I will speak to you. I don't know. I'm off now to Northumberland for a week, well, tomorrow. But I'm coming in next week for the NASH thingy, am I? Yes, I am. Yeah, so I'll see you next Thursday. So have a good week, everybody. James, all the best. Thanks, Robert. Bye. Bye.
Thank you.